Okay, how y'all doing? Still feeling casual here. I'm gonna move the light a little bit, kind of my face. So right now we're going to talk about HIV, which falls under the category STIs. I think it's a little bit of a special animal in a lot of ways. So we're going to talk about it and what's special about it. Part 1, overview. So what is HIV? The human immunodeficiency virus is what it stands for. It comprises 2 species of a lentivirus, HIV-1 and HIV-2. HIV-1 is more infective and more virulent. HIV-2 is relatively rare and mostly confined to West Africa. Causative agent for acquired immunodeficiency syndrome, condition characterized by progressive failure of the immune system. Remember that HIV is the pathogen, AIDS is the disease. Long incubation period, long period between initial infection and death, is transmitted sexually and through non-sexual contact with infected blood or fluids, with the exception of things like saliva, for example. HIV infects CD4 plus, CD4 cells, the helper T cells, dendritic cells, and macrophages. HIV infections lead to low CD4 counts, leading to a loss of cell-mediated immunity. Loss of immunity leads to infection by numerous other pathogens, leading to death. People don't actually die of HIV, they die of subsequent infections that they get because of HIV. So if you look here in this graph, CD4 counts vary over the course of disease. Being relatively normal at first, then dropping, and then going up again and declining over several years. And eventually they reach sort of an inflection point where they're so low that it's hard for the body to fight off infection from other pathogens. Rates of new HIV diagnoses per 100,000 by race and ethnicity. African Americans really are off the charts in terms of HIV risk. Whites and Asians are the lowest, so we're talking about marginalized populations. The legacy of racism and class in the United States directly impacts who's at risk for HIV. And there's lots and lots. We could have a whole course on HIV talking about different aspects of it. Poverty, right? Households, people who make less money have a higher risk of becoming HIV positive in their lifetime. Here's a great article that feature from the New York Times that I put up on Moodle, and I'd like you to read it, about America's hidden HIV epidemic. HIV is high among African American men who have sex with men, and this is true all over the country. And it's heartbreaking to read. I think that, and I'm not going to assume everything about what you personally think, but historically HIV has been approached here in the United States as being a disease of white men who have sex with men, but that's really sort of changed since the 1980s drastically. It's primarily disease of poverty and primarily disease of marginalized groups within marginalized groups. And I'm not trying to downplay the serious devastation that it waged on gay communities, particularly on the West Coast and in urban areas. I'm not trying to downplay it at all, but the problem is much wider than I think people would initially assume. Lifetime risk of HIV diagnosis amongst men who have sex with men by race and ethnicity. African American men, 1 in 2. That is crazy. I mean, that's unconscionable. I mean, that this occurs. Hispanic men who have sex with men, 1 in 4, and then white men who have sex with men, 1 in 11. I mean, it's. I think it's revolting. I think is the word. But this sort of tells you like where you should aim public health interventions. You obviously aim at the populations that are at highest risk. And in this case, it's African American men who have sex with men, who are marginalized people within marginalized groups. So, now that we've sort of framed HIV as a social justice issue, go back to the biology a little bit, life cycle and replication. maybe some of you have experience studying virology in the past. You might understand these concepts fairly well. For those who don't, this is the cycle here: attachment, viral exposure and host, penetration, virus enters the immune system cell, reverse transcription. The HIV's reverse transcriptase synthesizes double-stranded viral DNA from single-stranded viral DNA. Integration, newly synthesized HIV DNA moves to the host cell's nucleus where it's spliced in. Transcription, HIV uses the T cell to make copies of the virus. Assembly of viral proteins join to form an immature virus and are packaged to the plasma membrane of the T cell. Budding, the new virus exits the host cell, and maturation, proteases. Cuts HIV protein chains, individual proteins, and a new working virus is formed. So you can see here's another illustration of the life cycle itself. Viruses are amazing things, for sure. HIV infection sort of varies over time. HIV infection occurs in 4 stages: primary infection, clinically asymptomatic stage, symptomatic HIV infection, the progression from HIV to AIDS. You see sort of conversion within 3 to 6 months. Clinically asymptomatic HIV can be 1 to 10 years or even longer in some cases. Some people can start experiencing minor symptoms. Symptomatic HIV can occur 8 to 12 years following initial infection and then progresses on to AIDS. And this is not, there's a confidence interval here. I mean, there's a range. Many people are different. Risk per exposure event. Blood transfusions, obviously very easy to transmit bloodborne pathogens like HIV. Sexual or receptive anal intercourse is the highest risk sexual behavior here. Insert of anal intercourse less so, and then penile vaginal intercourse less so than that, but not zero. And oral intercourse, the risk is actually quite low. So, for example, I have a friend who was doing work down in Malawi, and she was trying to work with prostitutes in Malawi to get them to encourage clients to receive oral sex rather than penile vaginal sex as a means to control HIV, since men had such a problem using condoms down there. It's also been found that circumcision can mitigate risk of HIV transmission amongst during penile vaginal sex, and so circumcision programs are ubiquitous in sub-Saharan Africa now, especially in areas where HIV prevalence is very, very high, like South Africa and Botswana. Biting, spitting, throwing bodily fluids, these are all negligible risk. Saliva has a tendency to inactivate the virus, which doesn't shed very much in saliva anyway. So kissing will not transmit HIV. Definitely don't, definitely reassure people that can't happen, or doesn't happen very much. Risk by exposure event, by viral load again. Viral load and the exposure event or manner of transmission interact, so higher viral load in some cases can have multiplicative effects. Receptive anal can be very high for people with high viral loads. So condoms, use condoms, it's a good thing. Progressing to AIDS. AIDS is horrible. It's absolutely terrible. There's no other way to describe it. If you've ever seen anyone who has AIDS or suffering under AIDS or seeing their caregivers, you will know how devastating of a disease this really is. It used to be when I started going to sub-Saharan Africa, you would see people with advanced AIDS very commonly. Since the introduction of ARVs has become less so. I've seen sort of that drastic transformation in areas where there's high HIV prevalence. You would see basically what I no other way to describe it, zombies walking around, just emaciated and just in poor health, delirious. And now people are walking around sort of normal, completely normal. And that's really thanks to ARVs. As CD4 lymphocyte counts go less than 200 per milliliter of blood, symptomatic HIV infection can be triggered by the emergence of certain opportunistic infections that the immune system would normally prevent. These are simple infections that the body is usually easily usually easily fights off. This stage commonly is characterized by multiple infections that occur throughout the body, producing infections include pneumonia, enteric infections, eye infections, and meningitis. Physicians can treat the producing infection and illness specifically, but it's whack-a-mole. They also have to address HIV as the underlying cause. So that's why it's important to get people diagnosed and start treatment soon, not only to get them ARVs to prevent them from transmitting HIV to their partners, but also making a long-term treatment much easier. After a person has moved on to advanced AIDS, it becomes very, very difficult to treat. There's many different staging systems. CDC has lots of lab support, regular virologic and CDC 4-count measures that are used to define cases here in the United States. WHO also has clinical staging criteria, but requires less lab support because they're often working in developing countries who don't necessarily have ubiquitous access to labs that we would here in the United States. You can look at these on your own. Metrics for progress. So we've seen 8 new HIV infections go down. From 1990 to 2016, we had a peak during the 80s, early 90s, and then things have progressively gone down since the introduction of public health campaigns focusing on condoms and safe sex, and then the introduction of ARVs and PrEP to prevent transmission, prophylactic medications to prevent transmission. Percent reduction in new HIV infections, we're not going to necessarily make our target. I'm not sure that we did. Incidence prevalence ratio is down. Mortality ratio is down. Mortality is way down for HIV, which is a good thing. We've made massive strides ahead. HIV now is not a death sentence. It's mostly treated as a chronic disease at this point with proper medical attention and adherence to medicine schedules. A person can live a full, healthy life even with an HIV diagnosis. Globally, progress has been slow, but not none. We're definitely making lots of progress, particularly in certain areas of sub-Saharan Africa. Places like Botswana where HIV prevalence is so high, we've still seen new infections go down and mortality go down, AIDS-related deaths go down, and primarily the introduction of ARVs. Increasing long-term survival globally, people are living longer with an HIV diagnosis. Of course, this means that more people are living with HIV, but they're healthier and not dying as it's not a death sentence like it used to be. Prevention progress not sufficient for targets, so we're not going to make our targets. The target was to get it down to nearly 0 by 2020. Obviously, we're not there yet. And progress is plateaued outside sub-Saharan Africa. We're reaching sort of a point of diminishing returns. And this is the same thing as you saw when we talked about eradication elimination with polio. The final cases, the core cases, so to speak, are the hardest to get and hardest to treat. So, cool. I'm glad to have given you this HIV overview. It's very short. So if you have any questions, please hit me up because I am here to help you.